Hello, good afternoon, good morning, good evening, depending on where you are in the world. I am Professor Patricia King-Uri, based at the Ethos Centre and the Wellcome Centre for Ethics at the University of Oxford. We've got a really fantastic panel today to talk about ethics, misinformation, and the COVID-19 pandemic. We've got 4 great speakers, but I just want to go through just some of the housekeeping for us before we really get to the speakers. So this webinar will be recorded and it will be shared on the Global Health Network platform. Please use the chat box to introduce yourself for any technical issues. And please use the question and answer box to post your questions and topics. We'll do our absolute best to get through lots of the questions, but we mightn't be able to do that. But there are opportunities for you to engage in some of the discussions after the panel today. Can we just ask that because of the number of participants that your camera and microphones are disabled? If you'd like to speak, then I can invite you in, but you need to raise your hand and we'll enable your microphone. And can you please use the chat function for any technical issues and also message the Global Health Bioethics team. Thank you very much. At this point, it's my absolute pleasure to introduce our speakers. So we've got Professor Tim Caulfield, followed by Dr. Sam Martin. Then we've got Ms. Nora Adley, and then we've got Dr. Carolina Basista. These are 4 fantastic speakers who today are going to speak to the subject. Each has got 10 minutes. To introduce themselves and also to the panel. In the interest of time, we're going to put their bios into the chat function. And what we're going to do is we're going to go through all the 4 speakers, and then at the end, there's going to be an opportunity for questions. Just to let you know ahead of time that we're going to prioritize questions that actually intersect all of the 4 speakers, just because to make sure that we can at least address some of the issues in the time that we've got. Okay, so Tim, are you ready?
Anytime.
Okay, let's go. Looking forward to it.
Okay, well, thank you so much for this opportunity to talk with you guys today. You know, I think this is a hugely important topic and something that's going to be one of the great challenges going forward. And of course, what I'm talking about is fighting misinformation. The infodemic, I think, is completely recognized now as one of the great policy communication challenges of our time. I'm a professor at the University of Alberta in Canada. I've been studying this topic for years, and I've never seen anything like this. Not only with respect to the degree to which it has become a problem, not only with respect to the degree that it has had an incredible impact on people's lives, but I also think the degree to which it's been recognized now as a huge issue. And that, I'm not just talking about the World Health Organization, the UN, the FDA in the United States, Health Canada here, the National Health Service. Increasingly, people are recognizing this as an issue. But the general public is also seeing this as a huge issue. This was a study that came out in the United States not that long ago. It saw 95% of people saw the spread of misinformation as a serious issue. Similar data here in Canada. It should be 100%, but as someone who studies misinformation, it's good to see that so many people recognize this as a huge issue. And yes, the spread of misinformation is doing incredible harm. It's shaping the way that people see the universe. This is, again, another study that came out from the United States, very similar data, again, in Canada. 8 out of 10 people, 79%, believe at least one of the big conspiracy theories. And there's absolutely no doubt that these kinds of misperceptions about COVID are having an impact. I mean, they're killing people. There's no doubt about it. Misinformation is killing people. It's shaping health policy. It's increasing stigma and discrimination. It's doing incredible harm. Now, everyone involved in this event knows this. One question I always get asked is, what's different about today? Why is there so much spread of misinformation? Look, this is largely, not entirely, but largely a social media phenomenon. And there's, again, a growing body of pretty robust information to back this up. It's hard to study this well, you guys. We do empirical research on this topic. It's hard to get good data on this, but we've come at this from enough methodological directions that I think we can say with some confidence that this is largely a social media phenomenon. There was a really interesting study that, again, came out just weeks ago that they a survey of thousands and thousands of healthcare providers, and they asked the healthcare providers where are they getting their information. They said the number one source of misinformation, social media. This was a study actually done for my institute, 85%. Hard to quantify this well, but this researcher from the University of Alberta tried to put a number on it, and he came to the conclusion that about 85% of all the misinformation that's circulating in popular culture right now has as its origin story social media, and I think that number it feels about right as someone who's been following this research for a long time. Look, the other question I'm often asked is, what are the great challenges? You know, what's different about today's misinformation? While ideology has always played a role, ideology has always been a really big part of the story. I think it's becoming a dominant narrative right now. And I think it's important to recognize what I mean by that. As I said, ideology has always played a role in the spread of misinformation, even in the context of health. But now ideology is used to package. It's the vector that is used to spread misinformation. And let me just give you one really dramatic example of that. This was research that, again, came out just weeks ago. A colleague of mine, Frank Graves, is the PI on this project from Ecos Research. And just give you a sense of the overlap between ideology and the spread of misinformation. Look at this data. So should we have tougher sanctions on Russia as a result of the crisis going on in Ukraine? Of the vaccinated, 82% say yes. Of the unvaccinated, the vaccine refusers, those who are against vaccination, 75% disagree with that. Those are pretty shocking numbers. And look, we have to be very careful not to overinterpret the data, right? This is not causation data, obviously. This is correlation data, but that's kind of the point, the degree to which these worldviews can overlap. So important for a bunch of reasons, because it speaks to how are we going to address this? And we also know that once misinformation becomes part of your ideology, part of your personal brand, it becomes much more difficult to change people's minds. But the good news is we also have a growing body of evidence that tells us that debunking works, that debunking does work. Getting on social media with the right content, shareable content that's science-based, that's engaging, that uses different voices, that engages different communities, can make a difference. It really can make a difference. The concern about the backfire effect may be something that we can come to in the Q&A. I think that concern is often overstated. I don't think the body of evidence, again, really supports a robust concern about the backfire effect. So there is something that we can do about it. We can make a difference. You know, people often, how can we respond? How can we respond? Well, look at this data, again, very recent data here in Canada, where we ask Canadians, how should we deal with the misinformation on social media? And you can see it's pretty split, you guys. And I think this speaks to the challenge. 42% say the government should be regulating social media. 31% say it's only the platform's responsibility. Twitter, Facebook, Instagram, TikTok, it's their job. And 21% say neither. And I think that really highlights the challenge in front of us from a policy perspective. I'm going to end with our initiative. It's called Science Up First. It's our attempt to battle misinformation on social media. All you have to do to join the Science Up First team is join us on Twitter, Facebook, Instagram, TikTok. Come join the team. Let's fight misinformation on social media. It's a great community. Thanks again.
Thanks so much, Tim. And, really also thank you, because it's like really early in the morning for you. And I was so worried that you'd be really sleepy and lackluster, but obviously that hasn't been the case. And I'm really grateful for that. I'm just going to hand over now to Sam, Professor Dr. Sam Martin. Sam, do you have your slides ready to go?
I do. Thank you very much for the introduction, and thanks, Tim, for waking us all up on this this sunny day here that we have in London. Yes, following on from what Tim said, I work specifically in misinformation and vaccine hesitancy across social media, across all different kinds of platforms. I'm a digital sociologist. I work together with Patricia at the Ethox Centre at the University of Oxford, and I'm also a data analytics consultant, so I work with the University College London as well. And with Patricia, what we've been doing is we've been looking at vaccine hesitancy and misinformation as shared by healthcare workers in 4 different countries, so the UK, South Africa, Kenya, and Brazil. We're looking at not only misinformation, but disinformation. So specific information that is shared with the view to causing harm or changing different views. We're also looking at how healthcare workers are experiencing vaccine rollout and the kind of challenges that they come across across these 4 different countries. One of the questions that were asked of us at the beginning of this seminar was, well, how do we tackle misinformation? Do we have a task force? So do we have a team of fact checkers that might include psychologists and healthcare workers, or do we work with platforms? So do governments and Twitter and YouTube and Facebook, Instagram, etc., work together with platforms and public health departments to try to curb this misinformation? And then where we get to the extreme in terms of disinformation, do we talk about deplatforming? So for example, if you're thinking about just about a year and a half ago when Twitter deplatformed Trump, but then when you have deplatforming, you have the danger of pushing anti-vaxxers and those that are spreading all sorts of health misinformation to the underground and to other places where we cannot mitigate this kind of misinformation. So then how do we monitor for these new accounts and other things that are occurring? So one of the projects that we've been looking at is a hashtag that has been shared both pre-pandemic and during the pandemic, and this has been linked to vaccine hesitancy. This hashtag is called informed consent, and we've been looking at how this has grown and linked to vaccine hesitancy during the pandemic. What we found in our research is that it's grown quite a lot. So you can see at the beginning, well, kind of towards the end of the first year of the pandemic, December 2020, the blue wave of misinformation has increased exponentially up until the middle of August last year. Then there's been a dip as the vaccine took hold. And then of course, there's been an increase with coming towards the beginning of Omicron and the way that this has actually increased over time up until now. So the use of the hashtag informed consent has been linked quite strongly to hashtags linked to mandates, so no vaccine mandates, no vaccine passports, and also in terms of informed consent, in terms of bodily autonomy, people saying that forcing vaccines on people or having a vaccine mandate is essentially a crime against humanity. So there have been quite an interesting links to quite strong messaging around this hashtag and how this links specifically to vaccines in themselves. What we've found recently in the UK was the UK government said that they wanted to have a vaccine mandate for healthcare workers, specifically in the NHS and in care homes. And there was a lot of pushback again linked to this hashtag informed consent, where workers were concerned that if they didn't have a vaccine, that they would lose their job. Patricia and our colleagues also wrote a really interesting article about this called No Jab, No Job, and the ethical issues surrounding this. And what we also found when looking in the data from both in the UK and the US were people were saying, well, this is pro-choice. We had languages that were almost linked to anti-abortion. We had languages linked to previous mandates going through the NHS from previous years, and also linking kind of emotive wording, emotive hashtags to things like forced vaccination, human agency, freedom, things that were quite fiery in terms of how they were being shared, but also bringing a focus onto the difficulty of branding people who are talking about not wanting to be forced to have vaccines, also worrying that they're being cast as an anti-vaxxer and as a demon. So it's quite interesting to see how these kind of different language and discourse and wordings are kind of intermixed within the general discourse around vaccines. We also did a paper where there was a link between sentiment in terms of people who were against wearing masks at the beginning of the pandemic, and how this then linked into anti-vaccine discourse, and the differences between discussions around pro-mask and anti-mask mandates, and also in terms of people sharing information. So just in the bottom right-hand corner, we have discussions about TikTok being shared on Twitter, people amassing loads of information to prove their point, whether it's fully traceable or not. And in terms of the vaccine hesitancy and discussion, what we've been doing is looking at the discussion in terms of a continuum. So at the top you have refused vaccines, and at the top and at the bottom you have extreme positive views, but mostly vaccine hesitancy starts in the middle, where people are hesitant, they might delay because they might be pregnant, they might be worried about counteractions of medications that they're having, and then there might be some that accept cautiously. So where in the middle ground does vaccine hesitancy lie? That's been one of the questions that we've been trying to answer with our research. In terms of fact checking, we've been coming across different ways that governments and public health organisations have been fact checking. So we have in the UK, we have fact checkers. They are an independent task force that work hand in hand with Instagram. So you can see here an anti-Pfizer vaccine post on Instagram, where they work to have little notices that pop up saying that this information is partly false. You can click on the box, it will bring you to their webpage where they explain what part of a post is false and what part is based on the truth. This is also being pulled in, we found in Facebook, where not only we have UK fact checkers, but you can see we've got 1, 2, and 3. So we've got Science Feedback, which I think is US, we've got the UK, and then we've got the Healthy Indian Project as well. So it's a growing international task force that are working with these social media platforms. And then of course, if you have in a country where there's so much misinformation and it's hard to fact check every single one, then there's reliance on algorithms with links directly to public health information. So that might be one way that we can increase the way that we mitigate this type of misinformation. Another one is medical influencers. So I'm sure some of you might have heard of Dr. Mike or Dr. Jude, but they have quite strong voices where they tackle different health questions on social media, whether it's TikTok, YouTube, or Instagram. And they've been pulled in by the UN, by the WHO, and by their own national health organizations to have discussions with people on YouTube and to push out content that might be asking questions that people are having. And in terms of, well, what if you're researching misinformation? What kind of ethical issues might arise? I think one of the things is to always check with your own kind of ethical guidelines with the institute that you're working with. And even if you don't have a social media misinformation kind of ethical guideline, to follow what best practice is. And in terms of mitigating risk of those who it might be sharing questions about vaccines that they might be more vulnerable. One way is to think about, when you're reporting on this, to completely anonymize this kind of data, to take away usernames from posts that you might be sharing within your research, and also even just to summarize tweets rather than sharing them directly, so that these things aren't traceable. So it's a matter of kind of protecting the population that you're studying, but also trying to get a really good idea of the impact of misinformation, social media. And then my final slide is just that even sometimes even these measures aren't enough. Recently, I had a paper about long COVID. We took out all usernames, we took out all direct quotes, we left in some hashtags, and a couple of months after publication, someone found the hashtag that we had shared, and they said, I'm identifying myself as the person that started this. So it doesn't really matter what you do. The internet is so vast that the vulnerable users are traceable, but at least in terms of research, if you mitigate as much as you can, then I think kind of understanding and sharing information about what you're finding will be fairly effective. That's it. Thank you.
Thank you so much, Sam. It's absolutely fascinating. And thank you so much for trying to keep to time as well. I know it's lots and lots of information to try and pack into one presentation, but that was so interesting. And I'm sure we're going to get lots of questions related to that. So our next speaker is Nouran. Nouran, are you ready? You got all your slides ready to go?
Hello, so I'm Nouran. I'm working as community engagement officer at UNICEF Jordan, and my presentation will focus more on practical things, on how we used actually new tools and techniques in fighting this rumors and infodemic. So first of all, I will focus mainly on social listening. So what is social listening? So it's a new tool actually now used as a mechanism of the accountability for affected people, and its main aim is to gather feedback, to gather people's rumors, concerns, questions about a certain topic, and we also collect from it queries and questions and challenges faced by the community. So it's a tracking tool, it's a mechanism to collect feedback and also to keep monitoring the interactions between the community members. So why it's important, and as we all know, it's a good way that we have two ways of communication instead of one way of communication of messaging, and this leads to pandemic fatigue. So people are actually bored hearing many news or stories about information that might seem difficult to them. So they just need the bits and pieces that they need to know. Why should I get it? What's the side effects? Why specifically this happens to me? So we need to be more practical in responding to the community needs. So and it's also it shows how effective our interventions are. So this is a good two ways of communication that facilitates our intervention with the different communities, different age groups, gender, and also can reach different geographical areas. So the tools of social listening, it could be online and offline. So we do it both ways in order to ensure that we actually listen carefully to the community and the community needs. So this is basically the steps, the main steps of collecting or doing the social listening. It starts with collecting, and before collecting, we have to do the mapping, general mapping to the online and offline different platforms. Then we collect data through different community members. So in case of Jordan, we focused on youth. So we used youth actually to collect and to listen to the community members. And they report on a daily, weekly, and monthly basis, and we collect this information and analyze it, and then we categorize it and work as a bridge between the Ministry of Health, the other decision makers involved in the risk communication community engagement plan in the country, and the community. So we do this, we put specific keywords that can actually facilitate or help us in reaching the right messages, or actually listening to the right concerns and questions from the community. Then we deliver. So based on this, we have the evidence, and then we create or respond to the community needs by different methods. Like we created videos, stories, testimonials. We've done also theater shows. We've done other competitions in schools, or generally talent competitions, community initiatives, youth initiatives. All of this were like examples of our interventions and how we make the community like kind of engaged with us in the response. So this is the main steps, and this is the offline mainly, but also we have the offline, which is the Talk Walker. So we have also the Talk Walker tool, which is a tool to monitor the social media platforms used by UNICEF and used also by other private companies. So we use it to identify and verify the social listening content, and to verify the information coming from the volunteers. So yeah, as I told you, the offline part was mainly done by different target groups, community leaders, youth leaders, social and health frontline workers, and also through different focus group discussions. But the unique thing here is that we didn't focus only on the health workers. We involved the normal public. We involved youth who are not really related to the medical scene, but they are involved in the like making their community more healthy. So as I told you, like this is simply the steps, but in more detailed way. So we first engage. We have done this recruitment for a big team of volunteers. We do the mapping with them for the social media platforms, for the media platforms, for other actually informal groups on WhatsApp, or other groups of the faculty, for example, in universities. And we create this mechanism where we gather, listen, misinformation, rumors, concerns, challenges, queries, whatever. Then we analyze it, we categorize it, then we take action, pivot and run, pivot and run. So we just also not only go and message, but we follow up on the actions, we follow up on the community feedback, whether they like the language they followed, they engaged, or they didn't engage. So the values of the social listening also was important, that it reduced the gap between the community and our programs. It fed into the community initiative or the community engagement activities, so it makes us more connected with the community, and it strengthened the RCCE response generally in the country. And it can also be like a tool to amplify the community voice, so they are heard. And we also do this through live sessions. We interview doctors, we interview other health and medical stuff. So the ethical dilemmas, since our topic today was about the ethics and how we integrate this in social listening, and since I'm also a member in the ethics ambassadors team in UNICEF, so I would like to highlight some of the ethical dilemmas or challenges while conducting the social listening in the response to COVID. So of course, in keeping the confidentiality of the people, for example, we take screenshot, we take bits and pieces from conversation on social media or media, so keeping the confidentiality and make them not feel actually offensive about it is very important. And also we faced somehow a bit of inequality in reaching rural areas, especially in DOM communities. Like there are some communities who are difficult to reach, so making sure that we reach them through, as I told you, different channels, not only on social media. So we do monitoring the public conversation, the normal conversation, so they don't only listen or focus on social media, but also on the daily conversations in malls, in cinemas, or like when they were open, in supermarkets, taxi drivers, so they listen in places where people gather, and the family conversation, of course. So also there are new social media channels which is difficult to be monitored, of course, like TikTok, and also there are like social clubs, online social clubs, which was difficult to be monitored, but also this constitutes the ethical dilemma on keeping the confidentiality of the groups, and also reporting like the main trends in the community. So we focus mainly on the trends, not on specific or individual cases. However, keep in mind that we also need to be very specific when replying to specific, for example, health situation. So to make sure that we provided the right answer, and we also kept the confidentiality of the person. And another challenge was the inconsistency in messaging, which also creates more and more rumors as a counter feedback. So this is also was like taken as a lesson learned to, because sometimes the government say something, other agencies say something else. So, and different research where like many research were published. So we have to like make sure that we remain in consistency in delivering messaging. Again, the follow-up is very important, which is crucial in making sure that the interventions reach the right target group. We addressed this target group, and it should go both ways, like up, down, and down, up. It gets the messages from the government and from the official entities. Then we listen to what people are saying, and we report back to these decision makers. And also the balance between the online and offline social listening should be taken into consideration. So both should be done in parallel. We cannot depend on only one tool, because the online, it gives you broad inputs, but the offline, it gives you the detailed questions and the inputs that we were looking for. So by this, actually, Jordan now reached 5 million almost of vaccination. So almost 50% of the population got at least the first dose, and that was a success story. So thank you so much, and I hope this was useful.
Thank you. That's so interesting, Noran. It's really great to hear an example from, well, a success story, but also something that's going on in Jordan. Okay, so our last speaker is Carolina. Carolina, you okay to share your slides? You ready? Okay.
Sure, yeah.
I'll hand over to you. Great.
So thank you, first of all, Patricia, for moderating the session. Thanks for all of the previous speakers. I've learned a lot with you, and thank you for Catherine for inviting me for this webinar today. And I'll be basically sharing with you the role of communities in fighting misinformation in the COVID pandemic. I'm a physician by training. I'm Brazilian, and I've been working with community engagement and participation for many years. I currently sit on the board of Doctors Without Borders, Médecins Sans Frontières, and I also work with a Swiss-based health impact investment firm, and also I'm also part of the Lancet COVID Commission, where I try to always bring the perspective of affected communities and vulnerable groups as part of my experience, both personally and professionally. So basically, we all have seen how the COVID pandemic has disproportionately affected vulnerable groups around the globe. And this also stems from, the fact that these groups were more exposed to the virus. They had less capacity to protect themselves. They had less access to healthcare in general. But also, we've seen how, for example, in the United States, Hispanic, African Americans, indigenous people have had higher rates of COVID since the beginning when compared to, for example, their white counterparts. In Brazil or in Latin America more generally, where I've had a lot of experience with COVID since the beginning of the pandemic, we've seen similar trends with vulnerable groups experiencing much higher burden, both on morbidity and mortality of the pandemic. So all of the reasons have been extensively studied and published, and it has to do a lot with the lack of social networks and social protection, but also the fact that these people had also disproportionately higher burden of comorbidities such as hypertension, diabetes, which posed higher threats for developing serious COVID and dying from it. Basically, also, I think that these communities have historically experienced mistrust in the biomedical community. They have been excluded and neglected by health campaigns, and that, of course, has fueled the lack of trust in COVID, and also as Professor Sam has very brilliantly said in her presentation, that has to do with the hesitancy and how a lot of these people have had hesitancy to not only COVID vaccines, but also in how public messaging has been created and disseminated among them. As we've seen, my previous colleagues have said, the volume and the speed of information during the pandemic have really made it very difficult for people to catch up and to understand what kind of information is true, what kind of information makes sense, and to assess the accuracy of the information. So basically, this has led to a lot of the misinformation that really poses a threat into the public health and successful management of the pandemic, given that misinformation fuels, for example, vaccine hesitancy, but also makes people less compliant to public health measures such as masks and other measures. So basically, I think since the beginning of the pandemic, the public health officials have inconsistently and effectively engaged the populations, and mostly the vulnerable populations that have had chronic low level of trust in the governments, but also have suffered more the consequences of the pandemic. So what should we do? I mean, what should be done, and what have been the successful experiences with the communities, the affected communities, co-creating the solutions? So there's no doubt, and there is a lot of recent publications that point to the fact that the development and implementation of culturally appropriate interventions are a very successful way to mitigate the impact of misinformation among vulnerable communities. So this is a picture from Brazil. She's a nurse, and she's also an indigenous woman, and she was the first one among the indigenous people in Brazil to be vaccinated. And she became like a spokesperson for the community. She was a trusted member of the community. And that's really important, like trust, and trust matters. Whether it's the healthcare workers that work closely with communities and have long-standing relationships with them, community leaders, faith-based organizations or faith leaders that are trusted by the communities, but also all different groups and individuals who have a trusted relationship with the community. So this is really important because these communities have to be always co-designers and co-creators of their own solutions. I remember working with indigenous communities in different countries in Latin America. I've learned very, very early on that they have to be the protagonists of their own solutions, and they can't be the passive receivers of something that's created by outside people, but really understanding what they believe and how that situation taps into pre-existing fears, misconceptions, mistrust. But also, I think it's important that we acknowledge that they have chronically suffered from lack of access to healthcare, from exclusion, from all of these things that really generate this ongoing mistrust in the biomedical community. So the other thing that's important, and Tim really said that during his presentation, that there is also a very, very urgent need to create evidence-based messages, science evidence-based messages, but they have to be tailored to these communities and to vulnerable communities, of course, but throughout. And I think that we've also seen during the pandemic how governments and public health authorities oftentimes have not been able to catch up with the speed of misinformation and how fake news and derogatory information about COVID has been created, but rather they have maybe failed to create evidence-based, scientifically sound health information that is targeted to specific groups. So the communities, as I said, have to be the co-designers of solutions, and these are some pictures of how community groups, but also informal media channels throughout the world have bridged the gap and filled the gap that was left by public authorities, for example, or public health authorities in creating these solutions. And I think that's important to reiterate here, that there's no one-size-fits-all approach. Each context will demand some sort of specific information. And again, I think Noren has just told us about how social listening is an important thing. And I think it's important here to understand that we need to also assess the existing communication channels that are used or most used by the communities. And it can be radio, community radios, for example, phone messaging system. In a lot of vulnerable communities throughout Latin America, Asia, Africa, WhatsApp messages have been a main channel of information to be shared within the communities. Radios or faith-based gatherings and all of that. But also I think it's important here to say that the digital divide still exists. So in a lot of these very hard to reach remote communities, there's no internet. So a lot of this communication had to be, like we see here, a lady with a microphone sharing information and sharing the kind of messages that probably were tailored to target people's misconceptions or people's fears. And because at the same time, there is a lot of situations and communities that their first access or their entry door to the internet is through their phones. And a lot of this mobile phone operators, they give social media subscription or access for free when you buy like a prepaid card, for example. So a lot of these people are very easy targets for social media campaigns and misinformation campaigns. So there's always a need to counteract and also, as Tim said, to debunk those kind of fake informations. Another message here that I think it's very important is no blaming the victim. This community should not be blamed or should not be expressed as the victim, the victims of or the ones to blame for this ongoing misinformation campaigns or for example, vaccine hesitancy, but rather they should be always engaged and listen to understand what fuels and what is it that it's underlying their hesitancy and lack of trust in the systems more broadly. Here are some examples of communities being the co-designers. And in my hometown in Rio de Janeiro, in favelas, in slums, and they're really trying to share information and trying to share culturally appropriate solutions through graffiti, through the community radios, but also through murals in the communities and using these existing channels that I was mentioning earlier. Some recommendations, I can't stress enough that the communities have to be the co-creators of their solutions. And this is a nice picture from indigenous women in the Amazon region, where they design masks early in the days using their own kind of fabrics and patterns to be shared within the community. Recent publications have recommended a future research agenda to address misinformation and how it's spread. And it really, I think, will provide us with more knowledge and understanding of how misinformation is spread, who are the populations and the subgroups that are more susceptible to being influenced by misinformation, how it spreads in social networks, but also I would argue here also the importance of understanding how it spreads within more vulnerable communities that have no access to social media and internet, but also how can interventions help boost immunity to misinformation? How can we help people not fall into the trap of misinformation? And then a recent publication that I was involved with, we really call government leaders and global health communities to prioritize evidence-driven communication strategy in the COVID vaccine prevention and treatment programs, while healthcare workers should maintain a close engagement with communities with very strong social awareness and community participation. Thank you very much, and happy to take any questions.
Thanks so much, Carolina. That was great. And it's really great to hear from all four speakers. We have 15 minutes left and the opportunity actually to have some questions from the participants. What I've done actually is try to summarize some of the questions, just at least to try to get something that can intersect all of the different speakers. So the questions, some of the questions actually really touch on this idea around uncertainty as a kind of cross-cutting theme. So uncertain quality, so where some of the information is true, but some of it is false, but also kind of uncertain sources where, for example, legitimate scientific sources are revising in real time their positions and how these impact trust and ethical practice. So I just wondered, Tim, if I'll go with you first, if you had any comments really on this kind of uncertainty and how this really impacts practice, but also trust.
Yeah, I think it's a great question, and a couple points. Number one, I think we do need to recognize that uncertainty, scientific uncertainty, was not handled that well, I think, throughout the pandemic. I think particularly early in the pandemic. And part of that is because one of the foundations of good science communication, particularly in the public health sphere, is to be clear and is to be certain in your messaging so people have actionable items. But as everyone knows, the science was fluid and ever changing. And I think the story around masks has emerged as sort of a classic example of that. Very early days, we didn't have a lot of evidence about masks. That evidence accumulated very, very quickly, and the recommendations adjusted as they should, right? As they should. The recommendations should follow the science. There's been a lot of interesting research that tells us that the public, again, hard to study this well, but the public wants to hear about the scientific uncertainty. And if you're not honest about the scientific uncertainty, you do have the potential to lose that public trust. So I think what we need to do going forward, and I think we've seen this, I think that our institutions have gotten better at this, is to be honest about what the science says. Bring the public along for the scientific journey. Tell them about the big picture certainties. Vaccines work. Masks are an important public health tool, but still be honest about those uncertain things and what we are doing to fill in the gaps, those scientific gaps. I'm putting in a piece I wrote for the Globe and Mail called The Uncertainty Dance, Science Communication and the Uncertainty Dance. I think it is a dance, and I think we need to get better at it, but I think we did improve as the pandemic moved on. I'm going on too long, I apologize. One of the problems, of course, is that those who are pushing misinformation have, and you sort of implied this in your question, those who are pushing misinformation have tried to weaponize scientific uncertainty. That still happens. It happens every day on my feeds. We have to push back against that. Changing your mind based on the science is not a reason not to trust someone. It's a badge of honor. That's a badge of honor, and we've got to make that clear. Changing your mind based on the science is a badge of honor. It's exactly what you want science-informed public health institutions to do. Let's bring the public along for the ride.
Thanks, Tim. I'm just going to open that question up just to maybe different context. So Carolina, just from your experience in Brazil, do you think that scientists being open about their uncertainty and things that they have changed their minds about, would that work in the same way as Tim's described, or would that actually feed into more misinformation?
Well, I think the fact that there was a lot of politicization since the beginning of the pandemic, right? So there was a lot of, as Tim just said, people who were propagating fake news were really weaponizing the lack of certainty in terms of the scientific and the knowledge generated throughout the pandemic. It's remarkable how this is the global health crisis with the most amount of information ever. But also it comes with the bad kind of information. So I think in Brazil, there was a lot of attempt and to politicize the whole discussion from, masks don't work, to vaccines will cause disease, etc., to tapping into existing fears from, for example, indigenous or other vulnerable groups. There was a lot of speaking out and activism from scientists, but there was at the same speeds there was a lot of attempt to disfranchise the scientists. So I think there's something that we have to chronically try to address, and but also give voice and give visibility to that, but also mobilizing public health officials, but also policymakers to be very fast, or as fast as possible, in aggregating evidence and scientific information to counteract the misinformation that's generated with the pandemic.
Thank you so much. And what I really liked about your presentation, Caroline, and Nouran's as well, but you had really sort of strong recommendations as to manage misinformation. So I wanted to ask Nouran if she had any points to address around this idea of uncertainty, and how actually in the Jordanian context, whether some of the recommendations was actually to address this kind of uncertainty question.
Thank you so much for the question. Yeah, the uncertainty was everywhere. So it's really difficult to answer the question with like one or two specific points. But I believe that, like, since we create, I'm talking from a community perspective. So if we created a sense of ownership from the community, so they feel they are a part of the solution, we're not just imposing on them certain decisions or certain actions or interventions. So they feel that they are responsible for this. They are responsible for this uncertainty as well. Like, it faced all of us, so we all responsible to respond. So reinforcing the community influence through also community leaders, religious leaders, teachers. They are all these influencers who can influence this uncertainty and provide solutions how they deal with this uncertainty. And first of all, we have to accept, I think we have to accept that there are certain periods of time, there are certainty, and this provokes actually creativity and provokes this community approach of response. And I think this time was great in feeling that we're all in the same place, we're all sharing the same thing. So building on this makes the community feel that you're not alone, and we're not alone. I think it's not easy. It needs also psychological preparedness. So I think this also should be part of the institutions working in this, how to overcome these feelings, how to give the capacity, to build the capacity of the people working, whether health workers, youth, whoever, in giving support, and even the mothers, the family members who are in position of giving advice or directing people. So I hope this was useful.
That's really useful. Thank you so much. And I'm just going to ask a question to Sam, if that's okay. One of our last questions possibly. It's actually to do with this question of uncertainty, but now the question is about uncertainty around the definition of misinformation. So given what we've heard about the sort of the scientific field changing in real time, some of the ideas about what counts as legitimate or illegitimate information, how does then that change our understanding of actually what misinformation is? Because a couple of the questions I've asked, well, how are you defining misinformation? Not you personally, but as a collective, how are we defining it? So there seems to be also a question of uncertainty around the very definition of misinformation. I was wondering if you could speak to that as we close.
Yes, I found from the beginning of the pandemic that as information and the definition of what is real changes in terms of how do people catch COVID, how effective are masks, how ineffective are they, how do we understand the way that scientific literature is reported in the media, for example, when there are lots of preprints that are being shared as fact. Before academics themselves were saying, well, actually, this hasn't been reviewed by our peers yet. This is something that is still being investigated. So information changes and misinformation and the way this different type of information is shared is also evolving. So I think it's a matter of almost kind of having touch points on the journey to understand, okay, this was misinformation last year, but now that we have learned more, this is now what you would call genuine information. And then misinformation that is clearly harmful should be fact checked. We should be referencing back to health organizations. Is this true? Is this not? Is this partially true? And understanding that we just can't know fully what the real deal is until until kind of these touch points, these milestones have been passed.
Thank you. We've just got a couple of minutes, but I just thought, because it's related to what you were just saying, someone's just posted a question asking whether misinformation is more of a symptom than a cause of vaccine hesitancy. So often we speak about it the other way around, that, you know, these concerns around vaccine hesitancy creates misinformation, but they're asking if it's actually that misinformation is the symptom of it. I wondered if you wanted to answer that, Sam, or anybody else. We've just got a couple more minutes. Tim?
Yeah, sure. It's a great question, and you're going to hate my response. It's both. It's both. I think there's absolutely no doubt, and again, we have a growing body of evidence that tells us this, that misinformation, the spread of misinformation, Heidi Larson's group has done wonderful research on this. Misinformation causes hesitancy, right? The spread of misinformation, especially I think around that movable middle. But at the same time, we're seeing misinformation become a part of ideological groups, and in that sense, it's both. It's a symptom, right? It's individuals. We see these clustering of beliefs, and that, I think, it highlights the degree to which this is a very complex phenomenon. I will say this, because I often get, how do you define misinformation? The misinformation that is really stuck, that's really been circulating a lot, it's not equivocal. We're not talking about when do you get your booster and, what kind of immunity do you get from Omicron, where there is this ongoing scientific debate. This stuff is 100% bunk, that vaccines cause infertility, that the vaccines don't work, that ivermectin's a cure. It's stuff that was clearly misinformation. So that idea that, how do we define misinformation is often used as a way to doubtmonger. I call it doubtmongering, just to create the, information chaos. Let's focus on the big picture.
Thank you so much. And I'm not sure if you're able to see the chat or the speakers, but everyone's been incredibly complimentary of you. And thank you so much for such an informative talk. And I know that we could talk so much longer than an hour about this, but I know that we will have there are opportunities, I've been told, by the platform for some of these discussions to continue after the webinar. So thank you very much for everybody. And it was such a great discussion. Thank you.